where do we think we can still utilize the old school chemotherapy? For example, our US favorite regimen is TCHP, and the NeoCARP study, and there are also German studies showing that even taxane with HP can even be sufficient. We were even questioning the role of carboplatin with some recent studies, but now we are talking about T-DXd with the taxanes. We are now adding more options. So, how do we tailor that? Where do we give chemotherapy alone and maybe spare Enhertu for later if necessary? And where do we think it's crucial to bring in the best regimen right away? Like, how do you factor the patient characteristics to make that decision? Do you have an algorithm in mind?
Yeah, I think this is more the art of medicine.
Yes.
You and I have discussed. I think that when I'm considering, and in the study, of course, the T-DXd was prior to the THP, and many regimens in clinical trials now prior to DB11 have included THP with this question of the platinum, how much benefit are patients deriving from a platinum. So, I think if I have a patient with a pretty significant tumor size, multi-lymph node positive, overall healthy, limited comorbidities, I would have a balanced discussion with them to start T-DXd first, just like in DB11. If I have someone who has maybe just over the T2, the lymph node involvement is lower in the axilla, they may have a comorbidity, I might consider THP first and then image mid-cycle or mid-regimen to determine whether or not I should complete out with THP or move into T-DXd. But then that gives you a little more flexibility and tailoring to that individual patient. The other piece of that would be the hormone receptor status.
Right.
And whether or not, we really want to get the most optimal response for the individual patient based on ER status, positive or negative.
Right. Right. I think, I go through a very similar algorithm too. Like, I think disease burden is definitely going to dictate how aggressive we want to be. And I agree, like, if the patient has high disease burden, then it's reassuring to even tell the patient, I'm going to give you the best regimen that's out there with the higher rates of PCR. So disease burden definitely. And like you said, like, I also look at the ER-PR status. In my mind, and also from the studies we have, especially NeoCARP, when you look at the subgroups, those patients with ER-PR negative disease and HER2 positive disease, they are exquisitely sensitive to even a little bit of chemo, because the HER2 drugs are the ones that are really making a difference there. So in that ER-PR negative HER2 positive group, then I'm comfortable giving like a taxane-based HP-like regimen. Again, as far as they have a little bit of on the lower side disease burden to see how they are going to respond. And I like your idea of like flipping the order, where you can maybe start with THP or really not losing anything there, and then assess their response and make a decision to go for, T-DXd or not.